We do have one last speaker, that is Professor Brian Goh, who we heard from yesterday, who is the Chief of Surgery in Singapore and Director of the Transplant Centre and Hepatobiliary Cancer Centre, and an esteemed hepatobiliary surgeon. So thank you, Brian.
Thank you very much. I'm between you and lunch, so I'll go through quickly. So my declarations as per yesterday. So just some background where I'm from. I'm from Singapore General Hospital. We are the largest and oldest hospital. We were founded in 1821. And we are made up of 2,000 acute beds and 500 community beds. So we are quite proud to announce that we have been consistently ranked among the top 10 hospitals by Newsweek and the #1 in Asia. So these are some of the buildings in our hospital. Okay, you can't see, but the one in the center is the oldest building since 1821, is now the museum. On the top left is the heart center. On the top right is our cancer center. On the bottom right is our medical school. And on the left is academia, which is our office building. So what I'm going to go through today is robotics in liver surgery. So this is a nice review by my friend Ruben Syria from Spain. And in this review, he showed us the adoption of laparoscopy in the blue line, which came up rapidly in 2006. And then in the green line, you see about a decade later, which is robotic liver procedures, which started to really pick up only in about 2015. So we always talk about this learning curve. So one of my colleagues, Dr. Chua, he wrote a systematic review published in BJS about 4 years ago, looking at the learning curves in MIS hepatectomy. And in this study, first finding we found was, as expected, the learning curve of MIS hepatectomy was coming down over the last few decades. And when we look at the subset of laparoscopic versus robotic, as you can see in red, it seems that the learning curve of laparoscopy was about 43 cases and robotic was 20 cases. Of course, the big question mark is what is the learning curve? We know there's a difference between competency and mastering the procedure. And as mentioned by Iswanto yesterday, obviously you're not going to be a master of robotic surgery with 20 cases. So this is the main topic of my talk, which is what we have been asking, robotic or laparoscopic liver resection. We saw the RCT by Noor Rubari, but that's a small one. And this is what we have, a large database registry. Obviously, with a lot of biases, but let's just look at what we found. So this is an international study group we formed around just before the pandemic, where we started with 21 centers, and now it's expanded rapidly to over 80 centers worldwide with over 40,000 patients in our registry. So these are some of the centers from Asia, Europe, and the Americas. So almost every major center in MIS hepatectomy are involved in this study. So the very first study we published is also in BJS in 2021, where we just looked at a subset of patients, right posterior sectionectomy, and we compared robotic versus laparoscopy. So in this initial study where we had about 21 centers, we did a usual PSM matching for all those key baseline characteristics, including previous abdominal surgery, pathology type, cirrhosis, and even by the Iwate score. And what we found was robotic surgery seemed to be advantageous in terms of blood loss and open conversion rate, as what we've seen from the literature. So in this study, we concluded that both had equivalent or good outcomes, but robotic surgery for right posterior sectionectomy seemed to be associated with reduced blood loss and a lower open conversion rate compared to conventional lab. We subsequently replicated this study for various types of resection. So in JAMA surgery, we look at right hepatectomy. In the BJS, we also look at anterior sectionectomies, etc. And this table just summarizes the initial findings of our first group of studies. In that time, it was about 21 centers. And consistently, we seem to find that open conversion rates seem to be beneficial or lower in robotic surgery for all the various types of resections, including minor anterolateral segment resections, which are supposed to be the easiest resections. And also blood loss, as you can see in the red, seem to be advantageous for robotic surgery. So of course, these are all retrospective studies. There's information bias, it's non-randomized, there's selection bias, and importantly, the procedures were not controlled for surgeon or center experience. And the main criticism is that many of these robotic procedures were actually done by experienced MI surgeons. If you look at the background, like Dr. Noor Bari, he has been doing laparoscopic surgery before he moved to robotic surgery. So obviously the learning curve has already been overcome for MIS before he adopted robotic surgery. So this is the main criticism of this study. Next, we moved on to, this time we have already accumulated about 50, 60 centers. So we moved on to bigger studies. And this time we just look at robotic versus major hepatectomy, which was published in Annals of Surgery, I think 2 years ago. In this study, we had 4,822 patients, 892 robotic versus 3,930 laparoscopic. Again, we matched for all those baseline characteristics, but in this time, we tried to match for the center experience. So we included center annual volume, and we also accounted for the learning curve, which we arbitrarily decided as 50 cases. So the first 50 cases were controlled for in this TSM study. And then after the usual baseline characteristics, we also controlled by the IMM procedure code and the Iwate score. And then we look at the outcomes. So in these outcomes, we found that key outcomes such as operating time was similar. Blood loss was lower for robotic surgery, 300 versus 200 mils. Blood transfusion rate was the same. Open conversion rate again seemed to be beneficial for robotic. This was about 11% for laparoscopy and only 5% for robotic. And length of stay also seemed to be beneficial for robotic surgery. In the rest of the key outcomes, such as readmission rate, major morbidity, mortality, and major morbidity were all not significantly different between both groups. So again, in this study, we found a similar conclusion as our initial studies. Robotic major hepatectomy, when compared to laparoscopic major hepatectomy, was significantly associated with a reduced blood loss, open conversion rate, and length of stay. Next, we actually looked at the difficult posterior superior segments. So what we call anatomical resections or wedge resections in segments 7, 8, and 1, the difficult segments. Again, published in Annals of Surgery a couple of years ago. This time, 5,446 patients in 60 centers. And then finally, after excluding certain inclusion criteria, 3,510 cases, 461 robotic versus 3,049 laparoscopic procedures. In this, we matched for the same thing. I'm not going to go through the table, but the same conclusion came out about this. Robotic liver resection was for difficult posterior superior segments, again, was beneficial in terms of reduced blood loss, shorter operating time, and open conversion rate compared to lap. However, there was a thing that we feel that maybe it's due to the learning curve, which we will touch on later. Because if you look at the conversion rate, if you look at experienced centers today, a 12% conversion rate for minor hepatectomy, even in the difficult segments, would be considered high. And finally, more recently, we looked at limited resections or minor resections in the so-called anterolateral segments, meaning simple resections. Resections in segment 5, 6, 4B, and left lateral segments. And surprisingly, for this study, we again found that robotics seem to be advantageous statistically. So 75 mils versus 100 mils. Transfusion rate 3.1% versus 5.4%. Major morbidity 2.5% versus 4.6%. So there seemed to be some benefit with robotic, and again, the conversion rate was 1.2% versus 4.5%. So there seemed to be some statistical advantage in robotic surgery, but of course, if you look at the details, one would question whether 75 mils or 100 mils is going to make a big difference clinically. So I think we need to interpret this data with caution. We need an RCT, as mentioned previously, because retrospective studies, there are always going to be selection and information bias. There's going to be surgeon bias, and which we cannot know. So I think the best RCT would be compare robotic versus lab in centers we have already overcome the learning curve to account for all these potential biases and limitations in our studies. Finally, I just need to touch on our own perspective, because there's a lot of criticism of these things, especially for major lab centers. So our center if you can look at it, is mainly a lab center. As of last year, we do about 150 to 160 laparoscopic liver resections, and less than 5% of our cases are done robotically. If you look at the use of robotic HPB surgery in our hospital, the bulk of it today is for pancreatobiliary procedures, mainly for those requiring a complex reconstruction. So people like to ask me, so I decided to put this up. Are you a lab surgeon? Are you a liver surgeon? Or are you a robotic surgeon? So this chart just shows what I do. So I'm actually an MIS HPB surgeon, I would say. So as you can see from this chart, since 2011, my adoption of MIS has been increasing rapidly, but the majority of cases are still done laparoscopically, and only about 20%, 1/5 of the cases are done robotically. So what are the type of cases we do with laparoscopy in SGH? As you can see here, all types of resections can be done by laparoscopy. So about 1/4 of the cases are IMM grade 3, which are the difficult resections, and about 15% are IMM grade 2. But more importantly, a lot of these resections, as Iswanto mentioned, cannot be accounted for. So as you get more and more experience, you do a lot of more complicated cases, which I think the difficulty cannot even be graded on those scales. For example, 22% of our cases are cirrhosis. Even at this stage, I find cirrhosis the most challenging. Things like chemotherapy, fat steatosis, actually they are pretty easy to handle in a soft liver, but a hard liver is actually the major issue. We also do things like huge tumors stuck to the diaphragm, flat skin tumors, selected cases with tumor thrombus in the portal vein, hepatic veins. All this can be done by laparoscopy. So these are some examples. You can see huge tumors stuck to the diaphragm, abutting the hilum. Patients with a cirrhosis, portal hypertension, large tumors at the hilum. Unfortunately, transplant access is very low in our regions. So a lot of these cases, which probably be best done by a liver transplant, have to be resected. And this is a trisectionectomy for large HCC after Y90. So for those of you who have tried it, you know these cases are pretty challenging because the Y90 is supposed to shrink the tumor, but unfortunately it didn't, and it causes a lot of collateral adhesions and inflammation, making the resection difficult. And also we can do ALPS for very large tumors, which are, if you're interested in the technical aspects, you can access that journal article where we have a video of this. So if you look at the learning curve, so this is, we just put on this basic chart. So a lot of times we see conversion rate is a surrogate of learning curve. And many people say you need 20 cases, 50 cases. But when you look at our own experience, you just divide for the first 500 and to the next 500. You can see there is already a difference in the conversion rate. The conversion rate for IMM1 was 9.7% in the first 500, and it dropped to 0. For left IMM2, it was about 11%, and then it became 0. And for major hepatectomies, it was about 9%, and it dropped to 3.4%. And this includes those type of resections we mentioned earlier, huge tumors, ruptured cancers, etc. Then next, I look at my own surgeon experience. So these are cases which I only did by myself as a lead surgeon and does not include cases where I proctored or assisted my colleagues. So in this one, I divided 200 cases. So you see, look at my first 200 cases, the overall conversion rate was about 6%. And after 200 cases, despite attempting a lot of complicated cases, the conversion rate dropped to 0.4%. So I think just this data just shows you that the learning curve for laparoscopy is a little longer than what you think or you see in the literature. So based on this experience, in our experience, we feel that there's no major advantage for robotic versus lab after the learning curve for almost all types of liver resections. And we feel that if you do robotic surgery, it's unlikely going to be cost effective, especially if you can do lab and you're not going to convert. And I think you need to rationalize a limited and expensive resource. So for example, if we were to do every case robotic in our center, we probably need 2 robots for our department alone, which is not going to be cost effective. So in conclusion, based on international data, we find that robotic surgery was associated with lower conversion rate and blood loss compared to lab. But this is probably mainly due to the learning curve. And this experience is not replicated in major centers, high volume centers doing lab surgery. So based on our own experience, we feel that robotic liver resection is unlikely to be superior to lab for most type of resections after one has mastered lap liver resection. So in our experience, we feel that robotic liver resection should actually be complementary and should not replace laparoscopic liver resection today. Thank you.
We have time. I have a question. Right, so excellent talk. Really enjoyed it. Lots of data. Certainly there are surgeons doing high volumes of difficult laparoscopic livers. You're one of them, okay? And we all know some surgeons, both doing Whipple and complex livers. But there is an argument that the robot allows for more. It sort of levels the playing field. It allows for more people to be able to access that sort of surgery. How would you counter that argument?
So I think it's all about economics. So the issue here you're talking about is learning curve and volume. So obviously there are some places where they say centralization is the answer to that. So when you centralize, you increase the volume of an individual, the center, and of course cost comes down for the country rather than you have many surgeons doing many procedures and hence needing more high-tech equipment to get the same outcomes.
Thank you. Any other questions, panel? Emmanuel?
Thank you very much for your nice presentation. It's more a comment than a question. I think adoption of robotic liver surgery is already done. The problem is that how we will manage now the future of this platform, because we have an issue with the access. Not all hospitals can get access to a robotic platform. And then I think we should not think about going through, everybody has to go to a robotic program and abandon laparoscopic surgery. I think we should keep training people doing both, because I don't see that within 5 or 10 years, everybody in the world will have a robotic platform and every HPB surgeon can do both. So I think this is something we have to think about for the future.
Thank you, Emmanuel. I have another question, Brian, sorry. So if you have a hypothetical situation where you have both and you're running a high volume center such as yours, and you have a robotic series, you have a laparoscopic series, how will you decide which cases are done on which platform? And does that compromise the training for one of those platforms over the other?
So that question, if it's just personally me, I'm obviously more comfortable with the laparoscopic platform for liver resection, simply because I do more of it. So I think for every surgeon, it's going to be different depending on your own comfort level. And the problem with robotic, as you know, is access to the platform. It's very difficult for consultant surgeons to get their hands on it, much less you're going to get trainees, residents, registrars on it. So I think that's the major issue with robotic, unless the cost comes down and every OT in the hospital has a robot.
Thank you, Rafa.
Thank you very much, Brian. Very nice. And thank you for breaking up support on the laparoscopic surgery. I think that is the key message, please. We are now suddenly, and you've seen the papers, focusing on robotic versus laparoscopic, and we need to run a randomized trial. Is it not obvious that minimal invasive surgery is superior to open, and we need to promote that as much as we can? So, and this is what I would like to see, because we cannot go from here saying like, oh, I wish I have my robot and I wish I have my access to the robot. In the meantime, I'm going to continue to do this open liver resection for my segment 6 and my 7-7 and my non-anatomical resection. That is the message. We all have available laparoscopic surgery. We have a huge expertise around the world to find a mentor, a proctor, a simulator, and a way of training that. So please, it's available to everybody from today. So let's promote minimal invasive surgery and not wait for my £2 million robot to arrive. Laparoscopic surgery is better than open, proven, and based on very strong evidence. And robotic surgery as minimal invasive is matching that. I would agree that we will have to find the way of measuring the other outcomes, surgical professional outcomes, and innovation, etc. But at the moment, let's promote minimal invasive surgery that is superior to open. And everybody here goes out to push to get a robot, and in the meantime, do more laparoscopic? Thank you.
I agree entirely. I think the main message to the young doctors is you should still train your laparoscopic skills, go to the lab and train, not just think, okay, I'm going to do robotic surgery. I'm not going to bother to train my laparoscopic suturing, etc.
Thank you. We've got one final question before lunch. Thank you.
Hi, thank you. I'm Sasi Ramar, bariatric surgeon. Excellent talk. What is the cost difference between open, lap, and robotic at Singapore? And does it involve the human cost? Because the number of assistants you need for a robot is only one, whereas lap is usually more than one, and open, it's like multiple.
So again, every time you're looking at the individual procedure costs of the robot, but you do not look at the cost of acquiring and maintaining the robot. So if you do every procedure, if you say you already have a robot, you're going to do the procedure, then that's fine. But imagine if every procedure in your department is done by robot, you probably need to buy 10 robots. The cost of 10 robots is going to be a lot more than one robot. That if you are talking about saving costs, then you might as well say that you replace 10 consultant surgeons, centralize, and then you save the cost of 10 consultants.
Okay, thanks very much. We'll wrap it up there. Thank you.